Our next speaker is Dr. Daniel Scott, who's going to talk to us on how the actual financial process works with fellowships. Dan is from University of Southwestern Texas.
Great. Thank you, Bruce. I can tell you I had mixed emotions when I got invited to give this talk. First, of course, I have a deep passion for this organization. I think it has a very clear, good mission, and we need to support it. But I can tell you this is a sticky wicket and a difficult one to get your hands around, and I wasn't quite sure what I'd present because it's not something I feel like I understood a great deal about. So I've read a lot of literature in preparing for this one. I'm going to share with you some of the things that I kind of came across and hopefully enlighten us. This is some of Adrian's work looking at the need for fellowships and the cases that our residents typically get, which are in the green bars, traditionally have been far below the levels established according to expert opinion that are needed for establishment of competency. And so this data comes from a little while ago, but I think we've seen enough presentations at this meeting to feel like the theory here is still current. Similarly, when you look to the American Board of Surgery for data, lab chole is great. They get a lot of them. But what about these other index key procedures? Are we really going to make experts out of these residents in these areas of specialization that our fellowships represent? And I think the answer is no. If you look at the ACGME categories for minimum numbers, basic laparoscopy 60 and 25 advanced, any of us that are in the world of advanced MIS would argue that 25 is not going to get you there. If you look at GI surgery that some of our fellowship represents, 3 pancreas and 4 liver is what is required to graduate. And that's simply not going to be adequate to really develop any depth of expertise in these different fields. There are some lumped in categories of alimentary tract and abdomen that seem to have reasonable numbers, but again, that's for a lot of different material, a lot of different areas of GI surgery. When it comes to endoscopy, the numbers have recently increased and are listed here, 35 uppers and 50 lowers. But probably you need a bit more if you're really going to focus your career on this stuff. Additionally, there are some factors coming from the trainees. This data is from a paper in 2005 that looked at the perceptions of trainees and found that 80% of trainees felt that some form of advanced training after general surgery residency is necessary. The interesting finding that it wasn't just for academicians. It wasn't just for people that wanted to go to a tertiary care center and be a super specialized surgeon. It was also for community practice guys that wanted to have not only a better patient care ability, but also the market forces and the ability to go out and compete to get a general surgery job. They thought they needed extra fellowship training. MIS and GI surgical fellowships were the largest single group of fellowship programs following general surgery residency. Barbara Bass wrote this paper in the Annals of Surgery in 2006, and it's a very interesting one to read. She wrote that one aspect of the problem of our current training paradigms, she said, one simply cannot fit all of the required comprehensive didactic and technical training into our 80-hour-per-week residencies in the current 5-year model and achieve mastery in more sophisticated areas. She also documented the American Board of Surgery formed the Gastrointestinal Advisory Council in 2005, and one concept within this framework is to fold the expertise of gastrointestinal surgery back into the general surgery residency with something like a vascular surgery, specialized track, and early specialization. But I can tell you we're 5 years down the road and we really are not hearing this coming from the American Board of Surgery. And I think Dick Bell's concepts were very germane to this discussion in his address yesterday of how we would have to change things considerably to accomplish the goals that our fellowships are fulfilling. Adrian published another paper here in 2007, and this was an interesting survey, and I hope Adrian doesn't mind me presenting his data. but it helped me kind of in preparing for this talk. In 2006, he did a survey of 54 MIS fellows and compared this essentially with ACGME case numbers. Interestingly, these are gunners. These are guys that are interested in this area. The MIS fellows perform more laparoscopic cases than their peers during residency. So even before they got into fellowship, they knew that they were interested in these areas, and they racked up at more case numbers than the average graduating chief, according to ACGME numbers. Interestingly, these guys that did extra cases and had the extra interest did not feel competent to perform most of the advanced MIS procedures. When you look at the fellowship numbers, in addition to the residency case numbers, when you combine these, it gives you numbers that should provide competency according to surveyed opinion. So the conclusion here is that MIS and GI surgery fellowships meet a real need among graduating surgical residents. So we do not see alternative pathways coming to light. We will have to grapple with this funding issue, and that's really where I'll take my talk at this point. Now, talking for 15 minutes about funding options, I came up with 3 slides that I thought I could base my whole talk off of. One is that we find a pot of gold at the end of a rainbow. I don't think this is likely to happen. One is that we all, as program directors, start playing the lottery weekly. We sign up for it, and if we win, we distribute it annually to the programs. And then the third is that we take up bank robbery. Now, in all fairness, we have excellent leadership within the Fellowship Council, and I thought to myself, if I were going to suggest to the board who might do this, David Earle would be the perfect chair of the bank robbery task force. So David, we have a job for you. So getting back to kind of the meat of this talk, I thought we could talk about a few points beside these wish list items. Sammer nicely covered the GME Fellowship model. It's interesting, they view these as residencies. They do support fellowships, but they call them residencies. In surgery, the fellowships that are ACGME accredited basically boil down to vascular, plastics, pediatric, cardiothoracic, and some colorectal, and as you saw, there's even some thoracic that are not full-blown cardiothoracic programs and are not ACGME accredited. But the GME model is big. It's, as you've seen, it's grown over the past several years to have over 100,000 trainees in the program. It's funded primarily through Medicare payments, and this dates back. I thought this was interesting in history to understand this and to read about it. It dates back to the 1965 Medicare Act, where this got passed as a provision of public good. And the public good was that training doctors is a necessary component of health care in the United States. It breaks into 2 components: the direct medical education component, that is basically a calculation based on the GME cost per resident. I've read figures of anywhere from $40,000 to $120,000 per trainee, and I think it varies. Indirect medical education is the other component, and this apparently conceptually compensates for the increased acuity of care, residents ordering additional tests at different hospitals, perhaps staying longer in the hospital, etc. And the combined payments are made to hospitals or institutions, not to individuals, yet, as Sammer alluded to, another level of bureaucracy. And these total $8.5 billion annually. So this is a tremendous enterprise. This is a tremendous process. Even with it being this big gap still exists, controversy exists, ACGME accredited positions only. It leaves a lot in the cold, such as our group. The Medicare calculations have really been controversial because the number of training years supported and which one they count as your first residency versus your second residency appears in the literature as really a problem. The formulas also have been questioned. Apparently the numbers that they calculate the funding numbers off of have been capped at 1997 position numbers, and certainly 13 years of growth in different fields leaves some inequities. Budget cuts are apparent. Opportunity costs are not calculated in, and I think represent a significant gap in whichever model that you propose, because as we are teachers, we lose revenue from doing additional cases. We know it takes longer, and I'll show some slides along those lines. And then the academic opportunity cost. If we have pressures to do research or to publish, well, the more time we spend teaching in the operating room, certainly that competes. The GME model has supplementation. Even though Medicare is the primary funding source, as far as an identifiable source, it's only 40%. Medicaid makes up some of the gap in 47 states, but not everywhere. Other government funding, examples of that would be NIH funding. And then other is this huge nebulous bucket where it's not often talked about. And I found this article in the pediatric literature. If you look at funding, you really have to kind of scatter where you're looking to find good information. But patient care revenue cross-subsidies represent 49%. And that's hospitals getting reimbursements from one area and diverting them to another area, or practice plans diverting funds from their own pockets into the salary and cost of a fellowship. The cost of OR training really is not addressed in any of the models, and I found 4 good papers, and I'm going to share 2 of them with you that I think illustrate the points that are relevant. This is a paper by Babineau in 2008, and this was a community teaching hospital that started a rotation for a PGY3 surgery resident and looked at their data before and after this rotation started. I don't know if it does show here, I guess. Is simple operations added 8 minutes, complex operations added an hour. And you're talking about community surgeons added an hour per colectomy. That really hits home. This group estimated OR cost at 5 to 20 minutes. I've seen even estimates much higher. And they weren't so concerned about the OR cost, but they were very worried about the opportunity cost, the loss in productivity for these surgeons. So again, this in my mind represents a gap any way you slice it that's not currently addressed. Another good paper by Harrington that's right up our alley with some gastrointestinal surgery. Looked at one attending surgeon, had 12 intermediate to advanced level residents, and he had them on his rotation doing a laparoscopic room-wide gastric bypass and let them do basically the first half of the procedure, standardized when they started the ligament of Treitz identification, running the small bowel, creating a jejunostomy, and then had a very discrete endpoint. The residents took 94 minutes to complete this portion of the procedure, whereas his data indicated that faculty or finishing fellows could finish the same part of the procedure in 50 minutes. So you're looking at an additional time for this part of this complex procedure, 44 minutes. He went on to do a cost analysis, and I think this is very interesting. Only $1,500 for 44 minutes. I didn't have the heart to break down the faculty salary, but it was like $57 in his model. It hurts. But in any case, he did extrapolate to some cost here and just do some simple math. If you have 15 people rotating and they each get to do 2 of these procedures, you're racking up some costs very quickly. So kind of the message here is that there are gaps that aren't addressed. When we look at non-ACGME fellowships, Samer highlighted the different areas very nicely. I think it's worth looking at some of these other societies, some of these other models, and I don't think we have a good handle on it. This data does not appear published or even really on their websites, and we'll talk finally about our fellowships. So the SSO and the American Society of Transplant Surgeons, if you think about these, they're large groups, they're large programs. By necessity, anybody that's doing transplant has to have abundant resources. I mean, all sorts of people, man hours, financial resources, etc. And so that's kind of sets the background for it. And these 2 groups also have a very long track record, relatively speaking. In fact, the SSO is applying for their own certificates. So the non-ACGME accredited fellowships don't have board certification certificates. And so the SSO is kind of going down that exploratory process, and we'll see how that winds up for them. As far as funding, these groups, in talking to some of my colleagues in these areas, it seems that they're primarily funded through institutional support. The cost is supplemented by the fellow's clinical revenue. There's a faculty appointment for most of these individuals. They bill as an assistant, and this certainly can supplement the cost. Some moonlighting, some staffing of cases to augment their salary, sometimes as a job expectation to take other duties. Very little industry funding. When we look at our model of fellowship council programs, it's a little bit different. We have experienced rapid growth. We've got a very good foothold in the number of programs and in the number of positions, and that's been a very positive thing for our organization. But we have a lot of smaller programs, not abundant resources. I'd argue that we're a lot different from some of those other groups. And we have really nicely and importantly received help. We're primarily funded. 80% of our programs historically have been funded by industry. And I think that's really what we're here to talk about today. So I did an informal survey of some of the leadership of the Fellowship Council and came up with 13 programs that were willing to, on short notice, give me some information. These represented most of our core areas. Notably, endoscopy was not on there. But most of our core areas are represented. I can tell you the leadership that volunteered for this represents a wide geographical distribution and a lot of different institutional types. It's pretty clear that there are a lot of different expenses. And remember, we're not talking about those indirect opportunity costs, but these are direct, hard dollars that we need to run these places. Salary is the obvious one, but there's all the fringe benefits, and these vary according to the place considerably. Some places really have very little malpractice costs, and some places have quite a bit. Some people are charged for the clinic support to their fellow, which blew my mind because that's not part of my algorithm. But I can tell you each place is different. Academic expenses vary considerably, but we like to send our fellows to meetings. We like to have them present and make posters for them or edit videos or cover other kind of academic costs, send them to courses. Some programs pay for the board, some pay for licensing. And again, these are expenses, but they vary from place to place. When we look at Fellowship Council expenses, here really are the data that I was able to collect out of these 13 places. Salary, average $61,000. But a pretty big range, 52 to 70. Fringe, averaged 18, but this tremendously varied, $3,000 to $52,000. Academic expenses averaged $6,000, but ranged $2,000 to $15,000. And so you can see the distribution. The starting salary kind of hits that 60 grand line as perhaps the mean. And I think if we looked at this geographically, I didn't do this with this cohort, but it would probably vary from place to some extent geographically. And the fringe, a couple of programs with just a tiny proportion in the maroon bars, and then one program with a tremendous amount of dollar allocation to the fringe. And then the academic support is kind of this little yellow cap, in some places a little bit smaller than others, in some places very generous to do $15,000 on academic support. If you look at the sources, of these 13 programs, 10 were funded from industry across, if they received any funding from industry, and that's in these blue bars. So there's a couple of programs with only 1%, but I threw those in on this slide just for illustration purposes. And that accounted overall of these 13 programs, 51% of the monies total were from industry. It ranged considerably per program, nothing to everything. There are 2 programs in here, in fact 3, that it's everything, 100% blue. Department of Surgery, 1 program had funding from the Department of Surgery, and that's shown in this color, kind of this tan bar. And so it was 99% of that program's funding came from their department, with only 1% supplemented from industry. But on average, it's a minority. It's only 1 out of 13, and it accounts for only 8% of the funding. Billing as an assistant, 7 out of 13. So it's not uncommon to be able to bill for the fellow and to use those monies to supplement the expenses. But on average, it only accounts for 30% of the funding. Hospital, 3 out of 13 get some hospital support, but it's a low fraction, it's 10%. Other sources, 1 out of 13. In other words, a small 2%. But for this particular program, and it's this other shown here, it's a non-for-profit foundation, and it underwrites 25% of their fellowship expense. So I thought that was actually quite refreshing. If you break this apart a little bit more, here are the programs that receive industry funding. As I said, 10 get any funding from industry, but 8 receive major funding. And in these 8, it accounts for 82% of the monies that they report needing. So it accounts for a lot of the bang for the buck at these programs. Some programs it accounts for everything, and some programs it's not so much. If you took this away, this is what you'd be left with. And I think this has driven a lot of fears amongst our membership, and I commend the leadership for forming the foundation to try to find solutions. But this is what it would look like. 8 programs would only be left with about 18% of their current funding, and 5 programs would be left with doing pretty well. They have found alternative means. So that's really kind of the split on this snapshot of data that I was able to amass. The challenges, I think, are pretty clear, that we've heavily relied on industry funding to this point in our period of rapid growth. Recent changes in the guidelines related to industry relations really changed the dynamic, and that's what we're responding to. Alternative mechanisms exist, but have not been widely adopted. They run beautifully at some places, and the question would be is, over time, could we expand those efforts and give ourselves a little bit more long-term security in these areas through those means? Future directions, the Foundation for Surgical Fellowships, I think everyone is aware of. It was presented at the business meeting yesterday, and it's coming down the pipeline hard and fast to meet the need at hand. It will initially be funded by industry, but I think the foundation is being charged with exploring other opportunities like grants, hopefully not going into fellowship member programs, but certainly the Fellowship Council and its funding has been instrumental in jump-starting not only from a leadership but also from some seed money financial aspects. FC sponsoring societies would be another avenue that I don't think really has been fully explored, and we'll see how that works. Other mechanisms, perhaps pathways to increase billing as a first assistant for our programs, and then the ultimate goal will be long-term sustainability. So in conclusion, non-ACGME fellowships serve a vital role for the development of competency in select areas of specialization. Funding ACGME and non-ACGME fellowships is complex. I think the GME model is incredibly complex and fraught with problems. And these models are difficult given the current constraints. Gaps exist in both models, and the foundation represents a robust and important model for funding these fellowships. Thank you very much.